This video is about salbutamol. Salbutamol is typically used to treat bronchospasm due to any cause. This could be an allergen or asthma or induced by exercise. It's also used for chronic obstructive pulmonary disease. As a beta-2 agonist, salbutamol also finds uses in obstetrics. Intravenous salbutamol can be used as a tocolytic to relax the uterine smooth muscle to delay premature labour. The most common use for salbutamol, though, is in the treatment of asthma. Asthma is a long-term inflammatory disease of the airways of the lungs. It's characterised by variable and recurring symptoms such as reversible airflow, obstruction, and bronchospasm. Symptoms include episodes of wheezing, coughing, chest tightness, and shortness of breath. Common triggers of asthma include infections, particular infections of the upper airways such as cold and flu, allergens including pollen and dust mites, animal fur or feathers, and airborne irritants including cigarette smoke, fumes, and pollution. At the cell level, environmental triggers act on both the airway afferent nerves and airway epithelial cells to initiate responses and airway smooth muscle contraction, and these characterise asthma. So how does salbutamol work? Well, in conditions where there are narrowing of the airways, such as asthma, it is difficult for air to get in and out of the lungs. By opening the airways, salbutamol makes it easier to breathe. Salbutamol works by acting on receptors in the lungs called beta-2 receptors. When salbutamol stimulates these receptors, it causes the muscles in the airway to relax, and this allows the airways to reopen. So salbutamol targets beta-adrenergic receptors. These are G protein coupled receptors, and when activated, these generate cyclic AMP as a signal. Adrenergic receptors, though, are all over the body, and there are different types, alpha and beta, both of which have several subtypes. We're interested in the beta receptors. So the beta-adrenoreceptor has three different subtypes. Beta-1 adrenoreceptors is a predominant receptor in heart muscle. Activation of these results in cardiac muscle contraction, and antagonists of this receptor are potential cardiovascular drugs. Beta-3 adrenoreceptors are predominant receptor in fat cells. Activation of these results in fat metabolism. Finally, the ones that we're interested in, beta-2 adrenoreceptors are the predominant receptor in bronchial smooth muscle. Activation results in smooth muscle relaxation. So, if we're targeting the beta-adrenoreceptor, there are natural messengers, noradrenaline and adrenaline, but they have no selectivity. In the 1930s, a group of scientists in Vienna, including Richard Rossler and Heribert Konzett, were working on synthesizing agonists. Outstanding of them became isoprenaline, or N-isopropyl noradrenaline. The Viennese pharmacologists used their own Kronzer-Rossler test to examine bronchodilation. Isoprenaline shows some selectivities for beta-adrenoreceptors, and it is clear that it is the bulky isopropyl group that induces beta selectivity, but there was no selectivity between the beta subtypes, and there was also cardiovascular side effects. This leaves us to the person responsible for developing isoprenaline, and that was Sir David Jack. He was the head of research and development at Glaxo, the pharmacologist and medicinal chemist who specialised in the development of drugs for treating asthma. In 1961, as research director, David set himself the task of finding a more selective bronchodilator than isoprenaline, the non-selective beta-adrenoreceptor agonist, which was widely used at the time, that caused the unwanted side effects on the heart at doses that also cause bronchodilation, even when inhaled. David Jack is best known for the discovery of some of the most effective and widely used drugs to treat asthma and chronic obstructive pulmonary disease. He appreciated the importance of delivering asthma treatments directly to the lungs by inhalation to produce a more rapid effect and to have fewer systemic side effects than drugs given by mouth. Working with Roy Britton, he recognised the advantage of developing selective activators of beta-2 receptors to avoid cardiovascular side effects from stimulating the beta-1 receptors that were seen in the non-selective inhaled beta-agonist isoprenaline. So from isoprenaline, Isoetharine was found to show selectivity for beta-2 adrenoreceptors. The ethyl group induces beta-2 selectivity, but it was only short-lasting due to drug metabolism by the catechol-O-methyl transferase. So they realised that the phenol is an important binding group as a hydrogen bond donor or acceptor, but it was susceptible to metabolism, so they replaced it with different hydrogen bonding groups. The carboxylic acid was inactive. The ester was a beta-2 antagonist. The amide was also a beta-2 antagonist, so both not very useful. The sulfonamide, however, retained the beta-2 agonist activity and was a long-lasting selective beta agonist. Further development led to the discovery of salbutamol, which is the first selective beta-2 adrenoreceptor agonist. The hydroxymethylene group retains beta-2 agonist activity, and the hydroxyl group is shifted from the aromatic ring by one bond length. It still forms a hydrogen bond to the target receptor, but is not recognised by the COMT enzyme, which resulted in the metabolism. It has the same potency as isoprenaline, but is 2,000 times less active on the heart and has a 4-hour duration of action. Salbutamol was quickly marketed as Ventolin in 1969 and still remains the most widely used asthma drug in the world today. So let's look at the synthesis of salbutamol. Salbutamol is actually synthesized in a 6-step synthesis starting from aspirin. The first step is a Fries rearrangement in the presence of aluminium trichloride and nitrobenzene. Step 2 is an esterification of the acid using methanol and hydrochloric acid. Step 3 is a bromination using bromine to give the bromoketone. A nucleophilic substitution introduces the amine functionality. Consequential reduction of the ketone in the presence of aluminium lithium hydride in THF gives the secondary alcohol as a racemate. Hydrogenolysis using hydrogen and palladium on carbon finally gives salbutamol as a racemate. Levalbuterol is the R enantiomer of salbutamol. So salbutamol is given as a racemate, but it is possible to give only one isomer. The R enantiomer is 68 times more active than the S enantiomer. This is an example of chiral switching, which is replacing a racemic drug with a more effective isomer. Regardless of whether a racemate or single enantiomer is used, the duration of action was relatively short and patients had to use it frequently. So David Black and his team sought to develop longer acting analogues of salbutamol. By careful structure-function studies, they were able to optimize the duration of action by prolonging the time the drug occupied the beta-2 receptor. This led to Salmefamol. An N-alkyl aryl group was added, and the methoxy group interacts with a polar region in the binding site. This is an extra binding interaction, and it holds it in the binding site for longer. This was found to be 1.5 times more active than salbutamol, and it had a longer duration of action of 6 hours. Salmeterol was discovered through further structure-activity studies. The N substituent is lengthened to increase the lipophilicity, and this means it binds more strongly to the tissue in the vicinity of the receptor. This gives a longer-lasting agent, which is 2 times more active than salbutamol and had an even longer duration of action of 12 hours. This could therefore be used for nocturnal asthma, and salmeterol was therefore launched in 1990. There's our lipophilic side chain. So let's look at the adrenergic binding site. So what do we know about it? The aromatic ring forms van der Waals interactions, pi-pi stacking. The phenol groups form hydrogen bonds to the binding site, and especially in beta adrenoreceptors. The alcohol forms a hydrogen bond to the binding site, and the alkyl ammonium forms an ionic bond to the binding site. N-alkyl groups affect target selectivity. So the larger N-alkyl groups need to lead to selectivity for beta adrenoreceptors. What we mean by this is larger alkyl groups lead to selectivity for the beta adrenoreceptors because there is an extra hydrophobic pocket for it to occupy, which is not present in the alpha adrenoreceptors. Let's look about some side effects. So there are on-target effects due to beta-2 stimulation elsewhere in the body. Effects of inhaled beta-2 agonists on airways. The main action is in directly relaxing airway smooth muscle of large and small airways, but they may also act on 2 receptors of other airway cells, such as this may cause skeletal muscle tremor, glycogenolysis in liver, and inhibition of the histamine released from mast cells. Other side effects could be off-target, which involve beta-1 stimulation, such as relaxed gastrointestinal tract, and an increased heart rate or force, which can result in tachycardia or palpitations. So these types of medications are contraindicated in patients taking beta-blocking drugs such as propranolol. The incidence and severity of these side effects depend on the dosage and route of administration. Salbutamol is available as a tablet, syrup, inhaler, nebulizer solution, and intramuscular or intravenous injectable form. Overall, salbutamol is usually a well-tolerated drug, and serious side effects are very unusual.